So this is a 65-year-old female who comes in with no significant CAV risk factors. She has a BMI of 27. She presented initially with worsening shortness of breath and epigastric pain and reduced exercise capacity. She had an ETT that was done that was very positive for ischemia with ST segment depressions. And she was sent for a cath, which was done in April. And the cath showed 2-vessel disease with a mid-RCA CTO. And at that time, the syntax score was 24. And we elected to open the CTO, the RCA at the time. And she's done very well, but she continues to have disabling symptoms, despite being on both metoprolol and isosorbide. So the plan today is to go ahead and fix her LAD diag bifurcation, which is a Medina 111, which we'll show you here.
Oh, okay. So this is the, hold on, RCA?
This is the RCA CTO.
Yeah, we want to see, we don't see the angios. We're
You don't
still
see
on
it?
the
See the
slide.
angio? Yeah.
We're still, okay, now we're talking.
Fielder wire, fielder, yeah.
Okay,
Oh,
good.
beautiful result.
Okay. Yeah. So that was the CTO. I think
That was the
like he
CTO.
presented, this patient young, when you have a CTO, always try to do the CTO vessel first. Because you still, if you're unsuccessful or something, you can always consider referring for bypass. So this is where we are with LAD diagonal.
Beautiful
Significant disease. Yeah.
Yeah.
So now you know why she was still having symptoms.
Fielder,
Appropriately so.
Roger?
case. Dual LAD
Yeah.
system, huh? You have septals
Yes.
coming off the diagonal.
So let's discuss how would we handle. So why I'm thinking the last case, can we do it without imaging? Okay.
I will ask Dr.
Can
Babler.
we use our eyes?
Okay, what's the plan here? 2 stents or
We will, yeah, two-strand technique based on all the criteria, especially
Mini
definition
crush?
criteria, significant disease, side branch is large, side branch lesion is almost just about 10, 12 millimeters. So every criteria is telling us you
Yeah,
need two stents.
and here you have absolute no calcium by fluoroscopy.
Yes.
Yeah. This is a diagonal that's almost as big as, if
275
not bigger than the LAD.
Yep.
Plus the angle is
you've got to
very
use a
acute.
two-stent
You're
strategy.
going to have to do 2 stents. no matter
Yeah, yeah, that's a good point. Dr. La Sala is highlighting when the diagonal is so big, don't think about provisional.
No, two things. One, large significant lesion and side branch lesion is long. So three criteria, all three criteria are positive, will require two-stent strategy. Now somebody can ask, how do you decide which one will you wire first? Will you wire the side branch or the main vessel? Most of the time it is main vessel. In rare situation, we will say maybe side branch. If it's really, takeoff is angulated and we think the wiring the side branch is difficult, you will try to do the side branch. There are pros and cons. Like here, I wired the LAD. Now wiring the diag. Now that, like we mentioned, the vessel may straighten up. Wiring the diag may be
Twist the
difficult.
wires too.
So let us see how it behaves. Yeah.
That's your fielder?
No, I'm going in. Yeah, that's fielder. Yeah. Always try to use polymer jacketed wire to the side branch.
I have a very simple algorithm. I use a different color on the side branch so I don't pick up the wrong wire.
Yeah, yeah. So that is true too. So the fielder is green and our main workhorse wire, which is run through, is black. So you can see the difference. That's one. And that's where we are. Here, what we say is which side branch will you, or which branch will you open first? You can do main vessel side branch at any time because we're going to stent both. So that's how it is.
No,
But if you decide you're going to do provisional, always do the side main vessel first and the side branch last because you want no plaque shift
Correct.
after that.
Now, are you planning to do IVUS or OCT here?
Well,
Wolverine.
no, I said our eyes, EYE, eyes.
Oh, the eyes.
Yeah. Not ICE.
They have it written.
Where are we going? LAD?
Yeah, no. So we have a 275 cutting balloon. So we'll tackle the diag first, ostium of the diag.
Okay. Are we okay with that? Because the only thing we will need is the sizing here,
well,
right? Because we know there's no calcium.
Get the 3.0 balloon for the LED.
Is the
3.0,
panel in
215.
agreement to
215
use the
millimeter.
eyes?
Your wire came.
I think we have a quiet panel. Nitin Barman.
Imaging, we should do OCT.
It's easier to say. I think it's, this lesion would have qualified for a renovate, and I think that really post-imaging is probably more important here. And then we talked about this earlier, if you're going to post-image, then it doesn't make a lot of sense not to
Post-imaging,
image.
that's a good idea.
Yeah. That all said, I mean, I agree. I don't think that your upfront strategy is going to change too much. Just the kind of diameters and lengths, which are important, but modifiable post.
Get the main vessel balloon ready.
Okay, we
a
negotiated here for a post
Yeah.
PCI imaging.
I think post-PCI imaging, just so you're sizing it. I agree with Nitin. I usually tell my fellows, wherever the wire goes first, don't pull your wire back, just take the branch. So which one you're going to wire first. The big thing
What
here
happened is there's definitely entanglement of the wires.
Yep.
So let us see. I'm trying to get the cutting balloon. It's not going. If it still does not go, then means the lesion is
went.
tight.
You
No,
went
so I had to
through.
rewire. You see that? We rewired. Okay, go. This is a 270.
275.
Okay, good.
Anu, you always
use the
cut
same
balloon the side branches, huh?
Yeah, we are going to do
When-
that.
when you're gonna
See,
stand
there is a
there.
little bit of calcium. You see that now? Just at the ostium of that side diag. Yeah, there.
Yeah.
Okay, good. Down. I think 275 are a little large.
And when you have two wires and one's a fielder, you just have to pay attention moving in equipment that wire doesn't go distal. The fielder wire will go into really small vessels.
It's not opening?
Yeah. No, it opened up.
It's an
It
air
opened up.
That's the bubble, no?
Yeah.
That's a bubble.
No, that's a bubble, yes.
Okay.
Okay, let's take a picture. Yes,
Just,
big vessel,
yeah, get that wire out of that.
That's what you have to be
Separate.
careful with.
small one.
Nice.
Would you ever consider the diag as the distal main vessel here? I mean, the burden of disease is somewhat equivalent, but
Yeah. This is a good question Dr. Berman is bringing up. You know, for the syntax score, the main vessel is the largest vessel. In our
Yes.
field, the vessel that is in,
NC.
in the interventricular groove, in the anterior interventricular, is the LAD. So what do you think? When you have a larger diagonal than the LAD, you treat the diagonal as your main vessel? Not in this case. I
We
think-
have done that in in situations we have done it, but not in this case. I may be, they almost same, maybe slightly bigger. You see that?
Yeah.
You know, if you ask our European colleagues, they may say they would do a culotte here. Go
Exactly.
from
I was going to say
the
that.
left main to diag and then, stent the LED later. They like culotte. DK crush is not a bad choice. So like we say, the various technique, you just master a technique and just keep doing the same technique.
3015 NC.
For what?
Yeah.
LED.
Best advice for the audience.
Not the cutter?
For the LED we're using them.
So now, stenting wise, I heard somebody say do OCT. What was
No.
the reason they wanted OCT?
Oh, somebody wants?
No, post I know, but there was someone else mentioned they need
Yes, yes.
OCT.
A PPC OCT in fabrication, it helps in giving the exact angle of branch. Just to,
Oh, yeah.
And how will that help?
that will happen if it's a provisional. Here it's not a provisional, we are having a two-stent strategy
Okay.
beforehand. Otherwise, then help in predicting side branch loss or
Yeah.
plaque shift, help in assessing the plaque shift to the side branch.
So that's if you weren't going to stent. To decide whether, if you were going
I
to.
guess there are simple bifurcations.
That's a 3.0.
Complex
So
bifurcations.
what's the size now?
I think
This
a
is from the first group,
3024
What did we decide?
synergy. 3024, 3016.
Picture. 16 to the side?
Yeah.
We need 30. Oh, yeah.
Yeah.
So we are taking a 16 to the side branch and a 20 to the main vessel.
We need NC.
20 or 24?
Oh, 24?
I think-
Okay, 24 they want. Fine.
3024 for the main, 3016 for the side.
No, give me the side branch first.
Patrick, what do you think
Or
about
say
the,
always same thing, go to the side branch
Somehow-
or the vessel you think the delivery of the stent will be the hardest.
AK, the circumflex is crossing over the proximal portion of the LAD. The proximal portion's 3.5.
Yeah, or 4.0.
Yeah, we put a longer stand in the LAD. I agree with that.
No, we are putting 24. You want a longer than that?
24.
Longer with the 3.5.
I think you have to cover the first septal you see there.
No, with the 24 will cover all that, no?
Maybe.
Yes.
3 to 5.
Yeah.
16.
Okay, give
Probably
me
go
the
right
16.
back to that
It's
first
a great,
septum.
it's a great balloon result.
Right to the
though,
first
that
septal.
diagonal.
Yeah, the little tiny
You
septum.
may,
A
yeah.
little tiny one.
The issue is you may have a little dissection proximally. That's a good observation here. It doesn't matter. I mean, we just do the OCT at the end.
Okay, now give us I think 28 will be too long. We don't carry 26. That's it. Can we show the non-left main mini crush?
Get the other. It's done. 24.
Yeah, we have it in
24.
the,
Still
in the
24.
slide
Okay,
right
3 or
now. We
24,
can
yeah.
see it. So go over the technique, Anu. You park your stand on the diag after pre-dilating both.
Side branch, we use the word side branch because it could be anything.
Yeah, yeah.
Could
Side
be
branch.
PDA, RCA, main, distal, could be OM1, OM2, or a circ. So we say side branch, always, like I said, on the side branch, usually we say because delivering devices to the side branch is harder. Sometimes could be other way around,
Yeah.
right? So this is a 24. Now you see that 24 is covering what we wanted.
And this is a 3.0 also.
So, and always what's the size you will pick based on the size of the distal vessel. Now we are parked there. Now we are going to bring, see it?
Yeah, your dot has to be in the LAD. At least one.
Not really, yeah, we focus on micro crush. Okay, ready? Take a picture.
Yep.
You're still too far in.
Yeah, maybe a little more LAO.
I'm going to pull back.
Yeah.
Yeah.
You'd need a
Pull back
little.
into the LED, a little bit of mega crush here. Yeah, some dye. I think we are good, right? Okay.
You want to go to that view?
Why don't you get another
Okay.
projection? like
I would deploy it right now, but let's
do
go.
more
Let's
AP.
go.
This is RAO cranial.
good.
Yeah.
How about
I
a
wanted
cranial
to do
LAO?
that. LAO, okay.
LAO brings it out well.
See, you're
Yeah,
not
back.
covering the ostium.
That's okay. What happens is once we dilate, remember the LED stent
Yeah.
is going to do that. I'm going to pull back a little bit, okay? I pull back, okay. You don't want too much crush, yes. Go up in the side branch.
Side branch
it's
stent going
because
up.
of the angle of the
Yes.
bifurcation. Yeah.
This acute angle, you right?
Yeah.
Okay, good.
Mhm.
Down. Go up again. I think this is what John Lasala was mentioning, that they wanted a modified where I don't do it, but I know Nitin Barman does it, Samin Sharma does it. Go up. They bring the balloon back. Dilate here. Go up
And now you're doing it.
to show them.
Beautiful.
Why are
What
you
it
against
is.
that step?
Okay, so this is the most important part of the technique.
Now we have to take out the wire. Okay, give some
Exactly.
dye to make sure the distal edge of the side branch is okay. And now let's make sure. Okay, good.
Ready?
Some dye. I don't want to take a cine. Good.
Beautiful.
So I'll take this wire out. LED is good, right? LED is connected? Yeah.
Yep.
Give me some dye, so proximally we are okay.
Okay. Yeah.
Okay,
that's
good.
Perfect.
Go.
Yeah.
So there's a 3-0. Go more.
It looks 1-to-1, no?
Yeah, no, distal is 1-to-1. Proximally, we may have to post. Get us a 3.5, 12 high pressure balloon.
Get a 2.0 mini truck.
You're gonna use your same fielder to recross, or you're gonna do a new one?
Yeah, I will use the same fielder to recross. But before that, because there's discrepancy of the proximal vessel, let's just optimize and then recross. If we don't
Okay,
optimize,
okay.
they will always say that it is likely the wire will go behind the proximal part of the
Two of us?
stent.
No, we're going to pot it first. 3.5 first.
Sounds good.
Probably had to pull back more.
So they're great vessels to work on. Everything's expanding well and they're large size. So this is kind of ideal.
The only case today without calcium.
Yeah, it's the only case without calcium.
Yeah, we want the audience to take note of the fact that there's no rotablader.
No, last case also. Oh,
I mean, the case
okay.
isn't over yet, but
No calcium, no
Good.
rotablader.
Oh my God. Yeah, I think we missed the, okay, let's post dilate.
Yep.
Yeah, and
3.5, 12.
reaccommodate
And
the
then
LED
we-
wire too.
I'm going to fix that wire.
Oh, again, issue, yes. That's with the injection?
Yeah. No, it wasn't there before.
Going down a diagonal.
Nice,
We missed the
Okay.
ostium of the
beautiful.
diaphragm. Okay, let's do that. And we're going to use the same fielder wire to recross. Can we, you want the imaging, final imaging, right?
But you're gonna optimize the proximal?
Yeah, I'm going to optimize, then I'm going to recross, kiss, and then final imaging.
What's the length of your balloon? I don't want
12.
you to,
3.5, 12.
12.
better not to balloon that ostium again.
Okay, go. No, we want to because I think a millimeter maybe has been missed of the ostium down. So let us see. This was ideal. Now let's recross. You have the 2O balloon.
2.0 mini truck. 2, yeah.
So this is the
Ready?
side branch.
Beautiful.
Now don't even get me started with the crossing proximal and distal cell. You cross the optimal cell.
See, on
So we are going
fluoroscopy,
to
you
go with
see
the-
the line, the radio opaque line at the ostium that the LED stent creates. That means you have not kissed balloon
I'm
yet.
gonna take contrast.
That's important.
No, get it from the assist.
2 or 12 going in?
2 or 12.
Okay. And then we go with the 3O, high pressure to both vessels. I mean, 3O would go here, but if it's left main,
No,
you don't need to do like a small balloon first, but since it is non-left main, we are going to do a small balloon and after that we will go high pressure both.
You starting with a 3O to recross? I'll go
No,
2O.
I'm going with a 2O.
2O, perfect.
Yes,
Yeah.
yes.
Never,
Oh, you gave
no,
me
you
the.
went into the other wire, yeah. That's okay,
It went into the LED.
happens.
Okay, fine. I'm going to the.
well, one thing you
So
can do.
the same thing,
No, I was just going to
What was
say,
it,
okay, one thing you
Nathan?
can do, I know you can tell with tactile and you did a pot, which facilitates
Mm.
this, but sometimes before you recross the side branch, you can put that wire down the distal main vessel, make sure the balloon passes
No,
freely,
contrast.
and then pull the wire back and.
what did we open? IVUS?
OCD.
Oh.
Nice,
No, I'm not sure. You think we'll be able to get the OCT into the side branch?
yeah.
Go. Okay, 3O 12, both balloons, 3O.
20.
Okay, down.
Mm-hmm. I think you covered the ostium, Manu. Let's see.
No.
Let's see a little bit more. The next injection, you didn't do
Yeah, let
another?
us see. Let us see after kissing, and well, let's do the imaging and see.
What is this?
This is 2 or 12.
3O.
Yeah. 12?
Okay, so we're going both 3O, high pressure.
That's a 20?
It's
No,
a,
12.
Okay.
it's a pretty acute angle. The more acute it is, the more you have to crush, right?
Yes, that is a thing. So I think that's why we might micromillimeter the upper part. Let us see how it looks after we do the kiss. Okay. Okay, give me a 3O to the LED.
You do.
Okay. So let's do the OCT of the LED first and then the side branch.
Nope.
If we have difficulty in wiring, right? So many times the balloon may not go into the side branch. So then you take out your wire and recross to a different cell. That's why we use the word optimal cell. So, although there's a decay crush, non-distal and provisional, you go to the proximal, but as long as you know you've gone to the optimal cell and you know the balloon is crossed. If the balloon is not crossing, go to a different cell where you think.
Yeah.
We have to watch this part.
Okay, good.
Beautiful.
So we
Simultaneous?
can show.
Go in a little bit
So
on
actually
the-
bifurcate. What did you want?
You gotta come
I
back on
think
the,
you
or
should
in a little
go
bit on
in
the
a little bit on the
LED.
diag.
Diagonal, yeah. There you go.
Okay.
Okay,
And
good.
advance the
Go.
LED balloon.
Ready?
Not yet. We are not going to kiss. Go individual.
Individual.
Go individual.
Diag
So
first.
diag has to be go high, right? Good.
Yeah.
Yeah, I can
20.
see the ostium.
No, enough. Yeah. You see that ostium?
Yeah, I saw it.
Despite us cutting and all that, I think
you go.
it is not,
Angle? Yep.
didn't crush it well.
10, 12.
Okay, down.
Good.
Go to the ostium again. No. Go to the ostium of the diag again. We have to put another short strand there.
Would you consider a DEB there just for that, to spare a second layer in the side branch?
Okay, down. Yeah, we could.
やってもらっていいですかルーム2。
Okay, now kiss again, right?
Ready.
Go 8 both.
8.
Don't get crazy. Or 6 maybe even. Because so
6.
that's a 3 is too big. Down. So now you see that what's happening. Side branch, right? Go lower. You're not allowing to kiss. So many times maybe you can just do a serial. Okay, go lower on the LED.
You're on the LED.
On LED. Oh. Yeah. We're barely 4 atmospheres. 3O, the proximal vessel is barely like 3.25, not accommodating. So let's take a picture, then image. Ready?
Go.
So we're gonna end up doing culotte for that diag?
Not culotte.
But what else can we do? The 8 millimeter
Let us see.
will.
We have to put an 8 millimeter stent.
Yeah. Oh,
Right?
Yep.
yeah.
Leave this there. Get us. No, he's saying use a DCB, but I think now it will be a tap if you have to cover that.
Well, yeah, it happens.
There are questions in the audience about timing, but we want to
What?
see this. We want to, because we're 15 minutes late, but
Okay.
let's go ahead
Fine.
and.
Let's do the OCT of the main vessel. Good. And then you guys start your cases.
So just for people who use heparin, you have to keep an eye on your ACTs when the cases get like this and you have a lot of equipment in.
So it will be like a T approach for the 8 millimeter, Anu? Because the angle is not good for.
Yeah, it's a tap. Yeah, tap. Even then, the angle, you see that is so acute.
Yeah, the angle is
Likely
not
to
good
miss. That's
for
why I
a
was
T.
going back and checking. We pulled it. Acute angles, not the best. Okay, ready for OCT? Yep. Okay,
Full die.
Yeah.
ready?
Yeah, please check
Yeah.
the path.
Good, right?
Not coming yet.
Huh?
Laura?
Can you
Not
Wait,
correct.
video.
Hello.
My fault.
Ay, ay, ay.
Yes, again.
Mhm.
This is the last
Okay, we have to connect.
last-
Yep.
Give
Remember another one? No.
me.
Yes, the last case.
Okay, Proc, go forward.
6 speakers.
Go forward. Contrast? Yep.
Yes.
Forward. Good.
Okay. Now try now.
414. Okay.
Yeah. Got it.
You try?
Good.
Okay,
Yeah,
good.
good. Okay, 1 second.
Hmm.
Enabling, calculating. Yeah, Cine, inject.
Injecting.
Cine inject this side. Okay.
Yep, perfect.
Okay.
You don't have the angio.
Looks very good.
Yep. We'll see.
Okay, you can start your cases, right? We're just going to balloon.
Just tell us what
Switch
you're
it to
gonna
this.
do with the 8 millimeter. You're gonna put it like
Is
a
it two?
T
No, I'm
approach?
going to, no, what I'm going to do is go back with the high pressure 3.25 balloon. If it still does not look good, we'll put a short 8 millimeter stand. Tap technique, can you show the tap technique of the LED diagonal, non-left main on the side?
Yeah, it looks good. Normal position, no dissection.
Proximal edge is
Yeah, both
looking
it
good.
looks
Okay.
great.
Yeah,
Normal position, no
So we're
dissection.
gonna
and
start.
distal edge?
Yeah, distal edge also looks good.
Okay, excellent.
And the area-wise is more than 4.5. It's an optimal result. Main vessel.
Okay, fine. So MSA is good.
Yeah.
OCT MSA is a little different, 4.5. IVUS has to be 5.5.
Yep.
Okay, Pedro, start
Okay.
your cases there.